Today's speaker is Dr. Pieter Ekermans. He completed his undergraduate studies at the University of Stellenbosch, where he completed an MBChB degree in 2003. He pursued his postgraduate studies at the University of the Witwatersrand, obtaining an MMed ClinPath degree in Clinical Pathology in 2012. In addition, he completed a DTM&H in 2006 at the same institution. After this, he spent 2 years working in the Eastern Cape, based in PE at the Natural Health Laboratory Services. Since September 2014, Dr. Ekermans has been part of the Department of Medical Microbiology at the National Reference Laboratory of Ampath Laboratories in Centurion. He has a particular interest in mycobacterial diseases with a focus on non-tuberculous mycobacterial disease. Thank you.
Thank you,
for
everybody.
coming to present us this topic.
We'll try and liven up this topic. It's not an easy topic, and the more we repeat it, the better. And Norma and I are actually working on a position statement from SASCM, which we hope to publish sometime this year, on epidemiology and diagnosis of these diseases, because we are of the opinion that there's a massive gap in SA in its appreciation thereof. So now we have to go here. Yeah. So this is a wide range of pathogens within the genus Mycobacteria that range from strict pathogens to non-pathogenic saprophytic species. The immunological status is quite key to determine the potential that this organism or group of organisms can cause illness. NTMs are more than 190 species and are separate from TB, separate from lepra. Human-to-human transmission is generally not something that we're worried about, although there is some data to suggest in cystic fibrosis patients, there's a risk for transmission. And more recently, in a study from Osaka in a disability center, the potential for fomite transmission. This is fairly recent. And the big challenge is for clinicians to distinguish between colonization, contamination, and clinical significance. And the American Thoracic Society guidelines have not changed since 2007 because there's no easy way. You can't just do a PCR and that result equals disease kind of thing. And so we will talk about that in due course. This is an organism that is found in environment, in water, and in soil, and it's the process of aerosolization and inhalation of those particles that are contaminated that leads to infection and disease. On the topic of zoonosis, we don't generally consider NTMs as zoonotic disease. Just for sake, there's some work done in wildlife populations, and in this 2017 study, they found that M. abscessus subspecies Bolletii was quite commonly seen in lion specimens, just out of interest. But as a general rule, we don't consider it zoonotic. There is a few exceptions. So there's a species of mycobacteria called Mycobacterial genevensi, and it's the most common cause of cystine mycobacteriosis or NTMs in birds. And there's often in the case studies in humans a link to pets, birds as pets. And interestingly, in the 2007 ATS document, they say, if you think of avium, M-avium complex, and you cannot make the diagnosis, think genevensi. And we've actually made 2 diagnoses of genevensi already in 2 young boys, HIV positive, very low CD4 count. It predominantly has an abdominal presentation and less commonly a lung presentation. And so then in the big group of M. avium complex, there's a new player called M. Chimera, and it's one base pair difference to M. intracellulare, and has hit the news in recent years because of this link to contaminated heater-cooler units. And as the procedure goes by in theatre, this aerosolizes these contaminated water particles, and often these cases presented quite a number of months to years after the tonsillothoracic incision. And so interestingly, avium can be found in soil and in water. Intracellulare generally in soil, and what was previously considered intracellulare thought to come from water were all M. chimeras. And so there's often this issue of pseudo outbreaks with water contamination. It's additional. So that this can occur in immunocompetent and in immunocompromised patients. And there are reasons for primary and secondary immunodeficiency that make the host susceptible. Generally, we say the older the patient, the less risk factors there are, and the younger the patient, the more risk factors there are. Introduction besides inhalation might be from trauma or from surgery, and the surgery can be contaminated cocky pins to map out the abdomen kind of thing. And then in HIV positive cases, especially presenting the disseminated MAC, the root is probably through bias factors in the GI tract. So this a long list of specialities just to emphasize the point that it's not just pulmonology, it's not just infectious diseases specialists to worry about it. Our rheumatologists are particularly worried in their patients on biologics and steroids to complicate with NTM, so they are constantly on the lookout. In our gastroenterology patients, there's this link between M. avium subspecies paratuberculosis, and many of inflammatory bowel disease patients have this identified in the stool. The exact mechanism and link is still to be determined. So at the moment, just an association, which is quite interesting. We've actually had a nephrology case complicated with MRTS's complex with continuous ambulating peritoneal dialysis catheter tip, and the peritoneal fluid both positive. So we've seen that. And then foreign bodies, prosthetic joint infection is something which we've also seen. These anti-interferon gamma autoantibodies that is relevant to immunologists is often seen in the Far East, and then in pulmonology, a whole range of cases, cystic fibrosis, COPD, etc. Some of our cystic fibrosis pediatric pulmonology practices in Gauteng see a fair amount, and they are particularly concerned the link between a drop in FEV1 and lung function, and these patients would be treated actively. Not all of them clear it, but they are treated. And then in pulmonology specifically, the whole range of acquired and heritable causes or risk factors that make the host susceptible, and obviously it can be lifestyle, cigarette smoke, prior TB. Do not forget that in patients with history of TB, they are at risk because they've got structural lung damage. And so that's the milieu in which these NTMs can form biofilm and evolve. And obviously extremely difficult to get rid of. And obviously one of the reasons why we tend to treat these cases much longer than TB. So the body's response to the disease, symptomatology, radiological appearance, histopathology. These are all overlapping a multitude of other conditions, and we will go into them. And so from the immunological point of view, the big link in this activation of the innate immune response and eventually the adaptive immune response is the fact that NTM go and hide in the membrane vesicles in macrophages, where they resist the bactericidal response of alveolar macrophages. And in a bit more detail, this interplay between macrophages eliciting a T helper 1 response via interleukin 1, interleukin 12. There's also a T helper 17 response leading to T cell proliferation, neutrophil recruitment, and the eventual granuloma. A bit more detail. And then interestingly, there are these morphotypes. So it adds some more complexity to, you have M. avium complex that include M. avium, M. intracellulare, M. chimera, paratuberculosis, etc. And M. abscessus, the 3 subtypes, Maziliense, abscessus, Bourletii. And so in culture, we have these different morphotypes, M. avium, smooth, transparent, smooth, opaque, and rough, and abscessus just plain smooth and rough. And it appears that this rough form appears more virulent in experimental models. And in our lab, we actually capture smooth and rough colonies just to try and assess this link, if we can establish a link. And for many cases, the cases are clinically relevant, they end up being more rough colony morphology types. And how this works is the organism transitions through basically loss of glycopeptidolipids. And so there's masking of the underlying antigenic structures, and in very basic terms, is how this transitions. So this change in the cell wall of the organism. Sometimes, I mean, if you look at this, you think TB immediately. And obviously in our country, it's very high up on our differential diagnosis. And here, just, I mean, look at that slide B, enormous cavity. And in slide A, you can have, you toggle between nodular bronchiectatic disease and cavitatory disease on the other side, and obviously cavitatory more severe. And here is another horrific picture. And in fact, here, this was a Kansasii, M. Kansasii case. And in our country, so much work has been done in the mining sector. And we've documented M. Kansasii in the plumbing of dormitories in the mining. And so if you just imagine if your patient or individual stands under a shower, and that's a fantastic aerosolization procedure, if you think about it, but not so fantastic for the patient. And here in this particular case, there's history, industrial exposure, glass bottle factory exposure, granite factory exposure, and they made the clinical diagnosis of silicosis. And we know in this country, there was a class action with TB and silicosis patients. Yes. On the histology side, and I'm sure Norma has the same hassle, our histopathologists don't appreciate that this is not definitive diagnosis, and it's this constant fight between microbiologists and histopathologists, because many reports will say this is TB or this is MAC, but they don't always put the morphology is suggestive of. And it's important to realize the histologist might report on typical features or atypical features, and everything needs confirmation. Because in so many cases where they said this is TB, we culture MAC. And in so many cases that they say this is MAC, we culture TB. And our Gqeberha case from this hospital went through cycles of just TB treatment, then MAC treatment, and then TB and MAC treatment, because the initial information said this is TB. So just a humorous laboratorian aside, caseous necrosis, not just TB. When we think caseous necrosis, we tend to think TB, and only TB, but even syphilis, leishmania, fungal, in addition to NTMs, can cause caseous necrosis. Multinucleated giant cells, infective and non-infective etiologies can be relevant. And this is now just from 2 studies in bone marrow, where you can just see the differential diagnosis for granuloma. For so often, Norma, you agree? Granuloma equals TB. No, granuloma equals differential diagnosis, and marrying it to the clinical picture. And to realize, is it malignancy? Is it infection? Is it drugs? Foreign body? Is it connective tissue disease? And then obviously sarcoidosis, more into the diagnosis of exclusion. So then when we report acid-fast bacilli, we would have to ask the question, what's the clinical and the radiological plus or minus histological picture? Are our thoughts moving towards the big group of mycobacterial disease? And in this country, we need to rule out TB. TB trumps NTM for the most part. If the TB workup is negative, in recent years, there's now a direct line probe assay called the CM direct line probe assay at Ampath. To not avoid confusion, we registered it as the MOTT, the old name for non-tuberculous mycobacteria, MOTT, Mycobacterium other than tuberculosis, PCR. But remember, you still need to culture, and you still need to determine viability, and you still need to marry it to the clinical, radiological, and histological picture. The PCR on its own doesn't automatically equate to disease. Very important concept. And so this is the infamous ATS criteria for Dr. Kumar. And it's clinical plus radiological criteria, and crucially, exclusion of other diagnosing. I think if I think back of my undergrad and internship and comm service here, you just add the clarithromycin to the TB treatment if you have a mixed infection, and strictly the TB trumps the NTM for the most part, and you treat the TB first and reevaluate the NTM diagnosis at the end of the TB treatment. And I think there's that misconception that you have to throw, and it's important because your TB treatment will be in children 4 months, as short as 4 months, 6 months otherwise, whereas NTM treatment, it is much longer than a year generally for pulmonary disease. And if you don't describe day 0, and your monitoring gets messed up. And I think a big mistake then, people don't do the follow-up cultures, and then there's an indistinct period, and then they stop. So that's just an important point. From the microbiology criteria, we generally say 2 sputums, at least 2 sputums, 1 BAL for a histology plus a culture, where you generate your results from. So in other words, 2 sputums. Some say actually that the 2 or 3, they must be a week apart, not Monday, Tuesday, Wednesday kind of thing. to ensure persistence of findings and that this is not an intercurrent result. So another misconception. So two sputums, at least two sputums with MAC against the backdrop of clinical radiological criteria exclusion of other diagnoses, or one BAL with a MAC, or a histological picture with any culture with MAC, for example. And basically, sputum and BALs are equivalent in terms of specimen types, and generally bronchoscopy to be reserved where you cannot get a sputum specimen spontaneously or through induction, and you target for the most prominent lobe in the bronchoscopy. Sometimes from our pulmonologists, they would say this is upper lobe, middle lobe, lower lobe kind of thing, and it helps to marry the eventual results to what the radiology and the clinical impression suggested. Crucially, a lot of TB management in our country is clinical. And from my time in PE, what I often found is the clinical team or the doctor who made that clinical judgment call doesn't follow up the case, poorly communicates to the TB clinic sister, patient gets there, they don't see PCR or a culture, and then they stop. And then it becomes this vicious cycle of stopping and starting and stopping and starting. So crucially to make follow up with the same doctor or clinical team that has the notes. And when you refer to a clinic, to give good notes and judgment and your contact number that they know who to call, etc. I've also, from the experience of the last 12 years, where there's this very prominent clinical suspicion for mycobacterial disease, broaden the sample type that you send in for culture. And we've made a number of disseminated MAC diagnoses and HIV cases in this way. Don't just stick to one anatomy and sample that anatomy, broaden it. And in the lab, everything is about the quality of the specimen. How appropriate is it to the clinical picture? Does it represent pathology? Are we sending in a sufficient quantity? And then to ask the question, what's the distribution of the bacilli in the sample sent? Why I put that there is we sometimes get a discrepancy between culture and histology. And it's just a sampling thing. And then to remember, you can harvest the DNA from your histology if your culture misses it. And we've made successful diagnoses of TB in that context. And in some cases, the MOT PCR or CM Direct has also functioned quite well. Much of the diagnoses of NTMs are dependent on line probe assays in this country. These are membrane strips with probes complementary to the amplified nucleic acids that are extracted and amplified. And then there's a color reaction to allow us to see the banding pattern. I'll show you a picture now. There are various line probe assays in addition to the CM Direct or MOT PCR. The first three are for cultured isolates only. Common mycobacteria covers like Ansacii, M. abscessus, and Fortuita. The additional species cover the rarer one. So if CM says M species, then we will go on to do the additional species. And then in recent years, we've got the NTM drug resistance line probe assay that looks at the M. avium complex, M. chelonae, and M. abscessus complex, and gives you molecular-based or genotypic results for macrolide and aminoglycoside. And those are all follow-ons depending on the sequence. In the lab, because this is complex, I always say write on the form TB-MCNS, because for admin staff, NTMs, mycobacteria, these are foreign concepts. The workflow will sort itself out. So universally, everybody knows about TB culture or TB-MCNS. So it's just to not let subtleties fall by the wayside. And so on the midget tube, the midget is a BD system liquid phase culture that we inoculate the specimen after decontamination and concentration. Once it's positive, we use what we call a rapid antigen test and microscopy on that culture growth to decide, is the work going to a TB workup with the MTBDR plus or with the common mycobacterial line-probe assay. And to realize we've fallen into traps because with M. abscessus complex, there's a 2/3 homology with this MPT64 antigen. And you can get light bands, and then it's the work is shunted to the TB, and then the TB workup is negative. And then it actually is an M. abscessus complex. And the picture here is the microscopic arrangement of bacilli. So they look like cords. And TB classically cords, but M. abscessus complex can also cord. It has a thing called cord factor that allows for the spatial arrangement in the microscopy field. And so when we then look at the line-probe assay, you take that banding pattern and you flip it into the interpretation chart and you look for an exact match. The whole idea is not to see how many species you can fit into your banding pattern and say there are 5 or 6. It's an exact match. And so here, the top one, band 5 and 10, it's a Chelonay. Band 7 is one of the fortuitums. 4 is an avium. 5, 6, and 10, third from the bottom, is M. abscessus complex. 10, 12, and Sassii. And so you take that banding pattern, you put it in your interpretation guideline, and then that's how you make the diagnosis. As soon as there's overlapping bands, we look to see if there's a band 16. And you can see second to the end, band 10, 16. That's the trigger to make sure, am I missing TB? And we would shunt it for the TB line-probe assay to make sure we don't miss that. So that's the nice thing about the CM and the CM Direct. Although it's not your primary tool to diagnose TB, it has that mechanism to make sure you don't miss it. And as soon as there's any overlapping bands and there's no TB, we will say mixed infection or just mycobacteria species unable to speciate using the CM and the AS. So using this, it's extremely cost effective in a country like SA. In a first world country, they would sequence many of these. They have the money to do that. We don't have the money and the time to do that. So I'm a firm believer that if you use your line-probe assays correctly, it's the most cost-effective tool to make the diagnosis. And a few years back, we had a huge fight with the supplier who said, we're not making money with line-probe assays in this country, let's stop. And so we wrote, when Warren was still the head of SASCAM, the Lesh from FITSA and Prof. Moore, we wrote a letter and myself to motivate, and we managed to keep it. So thank God we still have that. And then another interesting development is the database from moldies. So this is the instrument in microbiology labs that we use to make our IDs for much of what we see on our culture plate. And in the database, it includes NTMs. And for extrapulmonary sites, we've often gone down the route of NTM workup because the molding detects it. And then we confirm it on line-probe assay. And there's even a mycobacterial kit that one can use that is sort of an improved version to access a better database. So that's also something that runs in the background that you don't need to request or worry about. But it allows us to make sure we don't miss these diagnoses, and this helps us a lot in the extrapulmonary setting. Just to remember, in the context of NTM disease, we don't use urinary lamb or Gqeberha to make the diagnoses. And for urinary lambs, we run at about a 6% positivity rate. 10% of 6% have culture with NTM, and 3/4 of that 10% have sufficient criteria to make the diagnosis. And so one of the traps is urinary lamb positive, let's start TB treatment, because the literature says in an HIV pause, less than CD4 of 200, if you start treatment, you save lives. But then the culture comes back, MAC, or M. abscessus or Gqeberha. It's now not the case that you need to treat both. It is most likely the NTM causing a false positive urinary lamb. With the Gqeberhas, where we look at the responses to these TB antigens in terms of interferon gamma release, there are some species that can give false positives. But in essence, we don't use these for diagnosis of NTM. Now, clinical significant MAC pulmonary disease is unlikely in a patient with a single positive specimen, but goes up to 98% when you have 2 or more. So 1 MAC doesn't equal disease. You need at least 2 against the backdrop of clinical radiological criteria, exclusion of other entities. So in MAC lung disease, you have these 2 forms, nodular bronchiectatic, cavitatory, and there are some people who suggest that in nodular bronchiectatic, you may have some time to watch and wait. You don't have to treat, but risk factors for progression include male sex, patients under 60 years, reference for that younger age, states cases under 60, low body mass index, cavitatory disease, elevated ESR, low albumin, anemia. These are all factors that may sort of indicate risk for progression. Whereas on the other side, cavitatory disease, you treat, you don't wait. If it's cavity, you treat. And then it's important to talk to your patient. So often, especially in our HIV cases, we have this phenomenon of stopping and starting. And then over the course of years, when we go back on our historical system, you see this picture. And then every time new people see the case and they think it's new presentations. It's actually one evolution from beginning to end. So very important to labor the discussion with the patient to make them aware of what is going on, because the treatment is long, more than 12 months generally. And because of the stopping and starting, we do see macrolide resistance. And so basically, if there are cavities, the ATS guidelines suggest to treat instead of watchful waiting. Now, from a treatment point of view, there's a lot of focus in recent years on getting the physiotherapists involved. And you can do a whole talk on airway clearance procedures, because much of the problems are linked to the gunk stuck in the lower airways. And as you can imagine, in cystic fibrosis patients, very difficult. And I mean, from Dr. Taban's experience in COVID, the effect that you had with going in with the bronchoscope to deal with those mucus plugs, you have that experience. In the guidelines, they have a dosing table, and it's important to realize, if you think, for example, of imipenem, the dosing is not 1 grams QID. Generally, the dosing, and Tigercell is another example, 25 to 50 once or twice a day, not 200 SAT, 100 BD. Because the duration is so long, this is also an attempt to manage side effects. So always remember to refer to this table for dosing. With MAC pulmonary disease, there's sufficient evidence to say that a 3-drug regime has better culture conversion. So there's been some recent controversy with some entities saying a 2-drug is sufficient, but I think, in my opinion, stick to a 3-drug regime, better culture conversion. From the ATS guidelines, they guide you for nodular bronchiectatic, and here, if treatment needs to be given based on your risk assessment, you actually can get away with a 3 times weekly dose, whereas with cavitatory and refractory, it's daily. But again, with the proviso with the aminoglycosides, that can be 3 times because of side effects. Refractory disease is if you have 6 months consecutive cultures that are positive. So you're not sputum converting after 6 months. Now, in recent years, there's been a lot of discussion on liposomal amikacin inhalation, and it's a pity that it is not available in this country because it's so expensive. So even Equity is not willing to bring it into the country because it's phenomenally expensive. But from this graph, you can see that at the end of 12 months treatment since conversion, there's a 63.1% that remained culture negative, and 3 months off treatment, 55.4% remained culture negative. It's actually quite phenomenal. But I think it makes sense because you're introducing a drug into a compromised lung that is bound to have problematic anatomy and physiology. So to me, it makes sense that these results are better than drugs taken orally. Now, in recent years, there's also been some discussion that moxifloxacillin and linezolid have fallen by the wayside and less important because of poor activity or higher resistance. In the past, we used to go to these drugs quite a lot. Interestingly, in the CLSI lab guidelines, they have in their table for drug susceptibility testing clarithromycin as a marker for macrolides, amikacin, and then linezolid and moxi. But they say with clarithro and amic, there's a much better in vitro in vivo correlation, whereas despite you have a reference range there, they cannot guarantee that when it's sensitive in the lab, it's sensitive in the patient. So that is even before all of this. And from this USA trial over the years of 2018 and to 2022, you can see the third and fourth column for the top various members of the M-avium complex, quite significant resistance reported. So then also fairly new authors that suggest rifampicin in the triple regime of rifampicin, ethabutyl macrolide is not the greatest, and that rifampicin might affect your azithromycin levels and drop it down, and that PKPD targets cannot be attained by safe and tolerable doses, high failure rates, etc., and suggesting that we need replacements. And so I'll share the talk with you. There's lots of work on hollow fiber studies. So this is work using semi-permeable fibers, closed cylinders with these fibers running through them, forming a closed loop with an inflow and an outflow and a central reservoir. So you're trying to mimic what's in the body and then perform assessments of absorption, distribution, metabolism in the circuit. And that's where a lot of clinical trials start off with, is in hollow fiber or murine models, etc. And so the replacement, okay, so here with rifampicin in this hollow fiber experiment, they compared a regime with rifampicin, ethambutol, azithromycin to ethambutol azithromycin alone. And in using cultured cells in this hollow fiber system, stasis of the bacteria, the mycobacteria, was obtained up to day 3, but after day 7, there was regrowth and macrolide resistance. And the summation that it didn't add to the antimicrobacterial effect of the ethambutol and azithromycin core in that treatment regime. And there was no alteration in transcription in that cultured cell using the rifampicin addition. So the replacement that they're looking at is clofazimine. So to not use rifampicin, but clofazimine. And in this experiment, they compared rifampicin, ethambutol, azithro to clofazimine, ethambutol, azithro, and they determined that there was regrowth after 7 days of the bacilli in the rifampicin-based combination regime, but the clofazimine combination regime maintained a decrease in the bacterial load and suppressed the emergence of macrolide tolerance. Another murine model where clofazimine-containing regimen reduced the colony-forming units in all organs of the mice, I think, and marked reductions in lung inflammation, and also had a treatment shortening effect. So there is some clinical data. This is from South Korea, looking at 170 patients, and the doses here, I think, were about 150 to 100 for clofazimine per day, and the longer you treat it beyond 6 months, you gained impact from the drug in the regime. So just a summary about the different phases of trials. And in a safety and dosing trial, there is one currently registered, not yet recruiting, and this is from the University of Oregon, using clofazimine-based regime. So this is not in the ATS. This is developments beyond the 2020 document. There's also work questioning the dose of 100, and that some authors feel that you need to give a loading dose for 6 weeks and then go down. And some authors feel that you go as high as 300 for 6 weeks and then go to 200. So that's also an evolution of thought, but beware of the side effects. And so important to get your ophthalmologist in to monitor for conjunctival irritation, retinal crystal deposits, etc. And then from a cardiology point of view, to monitor the case with an ECG for side effects. I don't think this is labored enough. Now, currently, for the pharmacists, we have ethambutol shortage, and it is available on Section 21. And so we need to continue the Section 21 motivation for it. But there are some authors that feel minocycline is a suitable alternative. And from my assessment in private practice, minocycline 200 milligrams is available in some sites. I don't know in Mediclinic, but definitely in Netcare. Then just again, monotreatment is a big no-no, because monotreatment, short regimes, guideline non-compliance, patient non-adherence, this leads to resistance. And in our country, this is a recent publication from Bloemfontein, where 2 of 133 M intracellulares had macrolide resistance. Generally, our macros are sensitive. At the time, just actually in the last 2 weeks, we had a case with disseminated MAC with a pseudo tumor on histology with macrolide resistance, and another case with pulmonary disease. All three specimens had RRL mutations on the NTMDR line. So we do see it, and I believe it's a stopping and starting thanks to that. Now, with this evolution of thought, the suggestion from international experts for macrolide-resistant MAC is to go clofazimine ethylbutyl amikacin. We're actually going to discuss this on Friday at the Stellenbosch NTM meeting with Prof. Frankie Dalyard as well. If there's anything additional, I'll let you know. And then a whole topic on its own. There's a lot of work done on bacteriophages, and this is relevant to our problematic M. abscessus complex, which is often viciously resistant. And I just showed you this picture. This is an agar plate with some disc susceptibilities, and you see the zones of inhibition around the discs. But you see the punched out growth in the growth areas. Those punched out areas tells us there's a bacteriophage in the cultured material, just to demonstrate how it looks visually in the lab. So generally, treatment in pulmonary setting, it's 12 months after culture conversion. So because we're in a cost-sensitive environment, I usually say, let's do cultures every month or every second month that's least. I think the British guidelines from 2017 suggest this as well. And once you have 3 successive negative cultures, you count them 12 months from the first negative. And that's the total duration of treatment. Another mistake that often is seen is we do a culture, we start treatment, and we don't culture again. And then there's no guidance in the approach. So there is some talk about using radiology, and obviously there's that risk to unnecessary exposure. But some sites would have different approaches every 3 months or every 6 months. And depending on the level of damage, the change might not be immediately evident in the subsequent images. So now, just the last few slides, the issue of combination infection. So there's actually very little information on this to guide us. This was a Russian study. And so they felt if your patient has an indolent course, hemoptysis, bronchiectasis, and unilateral lung destruction, to think that this NTM against the backdrop of TB might be more relevant. Whereas in XDR pulmonary TB in this study, they found that bilateral lung destruction is more indicative in the XDR alone. If we are dealing with the treatment of pulmonary TB and a subsequent low respiratory tract specimen that yields MAC or M. abscessus, in line with the guidelines, the diagnosis of NTM should be reevaluated at the end of the TB treatment. If these TB are cultured from blood, bone marrow, lymph nodes, that's a different story because that's most likely that is disseminated disease. And if we see Colonisation, this is one of the more virulent NTMs, we would also be more inclined to consider it relevant. So if we have more than one NTM species, what then? So we had this case of a cystic fibrosis patient where on the line probe assay, it was band 4 for avium, band 5, 6, 10 for abscesses. And so to demonstrate that there are 2 infections, because there's no banding pattern 4, 5, 6, and 10. There's a 4 and a 5, 6, 10. We re-decontaminated the midget, and the abscessus disappeared. And the repeat of the CM on the re-decontaminated midget, only the MAC. And so over the course of 2 years in the cystic fibrosis patient, we had dual, MAC, abscessus, dual. And so this patient cycled But we made this decision with the clinician, let's start the IV regime for M. abscessus complex. Patient tolerated 7 weeks of IV, and then we went over to an oral-based regime that had clofazimine, ethambutol, macrolide, and the patient went on for treatment for 2 years. But we didn't clear. Patient's lung function improved, and we made a drug holiday. And so more than a year passed. Now, more recently, lung function dipped. We repeated cultures, and we repeated many cultures, far more than 3, I think 6 or 7. And only the abscesses came up on all of them. And so in this current setting, we will gear treatment towards the abscesses only. The MAC came up at the beginning and never again. So sometimes you have to wait with dual infection and do a multitude of cultures and see which one comes up the most and target that one first instead of wanting to treat both. So every scenario has a slight twist in it. But in this study, there were 2 groups. 32 cases were cases not diagnosed with clinically significant M. abscessus lung disease, and group 2 were diagnosed with clinically significant M. abscessus complex disease. So these were cases that had initial combo identified, and group 1 were patients that were more likely to have single positive M. abscessus, where group 2 had significantly more total positive cultures of M. abscessus. And they had new or enlarging cavitatory lesions and met all 3 criteria for NTM disease, and hence we're started. So for other scenarios, we have an NTM and a non-mycobacteria. We see it in our cystics, we see it in our COPD patients, for example. And in line with the criteria, the focus is on the co-isolated organism, and to, as a broad rule, reevaluate the NTM at the end of the treatment once the initial bacteria, fungus, virus, or PJP is managed. But it depends on the risk, and it depends on where the NTM is cultured. So pneumocystis with MAC on blood in an HIV case, you will treat both kind of thing. And it's crucial to have those discussions in this multidisciplinary forum, like we have here at Midstream, to make that call, not just to treat everything. When a non-mycobacterial pathogen accompanies a positive PCR or culture for TB, TB complex treatment should not be delayed, and that will be prioritized. So if there's anything that you walk away from today, those criteria need to be followed to the T. You need to think clinical, radiological, and microbiological. Exclude other diagnoses because that needs prioritization. Have those discussions with your patients to make them understand. And I've even been called in to help with that. And it does help to bring in your microbiologist to come to the bedside to explain it. I've done that before. And then crucially, please follow up, do the follow-up cultures. That's very important. That's a big problem that I see happening. I reflect back on the last one. A lot more I can say. I can go on for hours. Norma has had to put up with me in the meeting group and had to keep me in check. So I blabber on. Thank you, Norma. No, it's a fascinating group of diseases, and we got very many interesting cases.
Thank you so much, Peter. I think that's clearly you've got a passion for MTM. We love that because it's really not an easy kind of topic to tackle down. And it's really, when you read it, you get bored in the middle because the names are difficult to pronounce. It's a nightmare, let alone the treatment. I just got two questions.
Yeah.
One is the role of predactyline in NTM in abscess.
Yeah.
The second thing about in pulmonology case, we have fellows here who are about to write exams.
Yeah.
The role of actually positive culture of NTM in the context of normal chest radiology. When do we consider if you have to spend?
Yeah. So the thing is, predactyline, I had a whole long to and fro with the Dutch team at the University of Nijmegen, which their feeling is that predactyline, there's publication bias. So Prof. Warren has from Stellenbosch has published a review with his team on predactyline. And it seems, if you read that at face value, that it has value. And even the Americans, like David Gqeberha and Joel Daly, in their work, use it in the macrolide-resistant scenario. But the big concern is the MICs, we don't have a way to test for it. There's no methodology to test for it. And in this country at least, but from the Dutch work, they have determined the MRCs to be 10 times higher from their methodologies than TB, meaning that you most likely cannot actually attain levels sufficient enough to deal with those MIC scenarios that are elevated. So there's a book that I bought from the American authors mentioned that has a whole sort of scheme that I used to follow where you can add clofazimine to a RIF-ethambutyl amikacin combination, and you can substitute predactyline for your RIF and then add your inhalation. But there are some questions on the validity of those studies. So that they are vehemently against predactyline, and they are firmly believers of clofazimine. Then in the scenario where you have normal lung functions with culture positivity, this is actually a scenario that is often seen in critical care cases, and it's because in private sector, as part of our low respiratory tract workup, we have AFB built into it as a sort of a rough scheme to assess cases, and because of that, we've picked up many TB cases over the years that the clinicians didn't feel to think of initially. But very many of these cases lead to NTM diagnoses, and they are most likely colonizers. And I would not treat that. If there's no radiological change, I would be very hesitant to treat. It's also important to think about the organism that you're dealing with. And so if you think of M. fortuitum and M. chellonae, these are rapid growers. So at its easiest, you have rapid growers and slow growers. Rapid growers are M. fortuitum, M. abscessus, M. chellonae. Slow growers are your MACs and your Cansasias. These other things about photochromogenic and scotochromogenic and all of that, this is historical. Don't worry about that. That's not relevant clinically. And so pneumonia due to chellonae is for me an incredibly difficult diagnosis, because I think if you look at the literature, and very many of those, it's colonization. Very difficult literature, and I've tried to find all the chellonae pneumonia kind of settings. It's not as solid as the MAC data kind of thing. And so what I'm trying to say, before we say this is M. chellonae pneumonia, clinical, radiological, other diagnoses to be excluded, but also consider histology. I would be more inclined that if we have chelone and AFB on histology from bronchoscopy, that this is more likely indicative of M. chelone pneumonia. I've actually yet to come across a true M. chelone pneumonia. So the organism that you're dealing with also plays a huge role in how to think about it.
I've got a question, but it's probably more for severe
Yes.
as well. So, the treatment, you're of the, so the treatment is 3 times a week,
For not in the
Yeah. So if a patient is HIV positive on ARVs, now the dolutegravir that you increase, do you also then just increase it 3 times a week, or do you continue with dolutegravir every day, double doses? In the sense that the patient on combination therapy with TB, we increase the dolutegravir extra. We give her 50 milligrams extra. So now with the treatment and then the patient that's positive, do you just then give dolutegravir 3 times a week, or is it like every day?
I actually don't know, Connor, but my thinking would be that it should actually be safer to just increase it on a daily basis.
Me too.
That's what you'll say.
Even if they're not taking.
Yes, because I think Brian said your PIP is going to affect, so I would do it.
Yeah. It's there.
Okay, we're running out of time.
Yeah.
Quick short questions. Good point. Yeah.
Okay, thank you, Dr. Pieter, for a great presentation. 2 questions. One was on the PCR. So you
Yes.
cannot make diagnosis on PCR. But if you had a PCR and an AFB, would you then start treatment for this patient?
No, culture.
Culture.
So it's important. So remember, we have time. So here you have time, and this disease process is not going to rapidly evolve like the Legionella pneumophila pneumonia or strep pneumonia, which we know are the 2 pathogens that are vicious and can get a patient to end up on an ECMO incident. So you have time. It's best to do the effort to send in the cultures to prove viability. Because we've had scenarios where the CM direct or not PCR is indicative of an organism in a pulmonary specimen, then it doesn't grow. And then what do you do? So the crucial thing is, I would always say, culture positive result tells you you're dealing with viable organism. And it's crucial to ensure that we've proven viable organism or culture positive, because that sort of adds to the idea that maybe this is driving the clinical picture. It's not just upper airway colonization. So we had this idiopathic pulmonary fibrosis case from Queenstown in the Eastern Cape. And both us and Gqeberha actually resulted it as M species, because both our labs sent it out, did CM and then AS, and couldn't call it. And they yet continued to send in, thinking that this is driving the idiopathic pulmonary fibrosis. And so eventually we did sequencing, and the organism grown was a mycobacterium Gqeberha, which is a very unusual organism, and the literature doesn't help us at all to guide. And it is most likely that that's an innocent bystander. And there was no evolution of disease, etc. there. So it's important to look at those risk factors for evolution and to reassess over time. So my summation of that situation, it was most likely colonized in a lung was completely compromised structure.
In the case of M. abscessus, right, you have to wait for sensitivity before you start your IV drugs. Or can you go for, you say, imipenem,
So basically,
before the sensitivity comes out?
So basically, we'll have the molecular result first. The NTMDR will tell you which subspecies you're dealing with. So you have Mazzelliense, which tends to be the more sensitive one. You have Burlettii, which tends to be the more resistant one. And in the abscessus, Some types react more like a mesallianza, some types act more like a Bulleti. You'll get a result for the macrolides, and the macrolides, there's banding patterns for inducible macrolide resistance, which we tend to see with abscessus, and Bulleti. That gene is inactive with mesallianza. I have not yet seen RNL mutations, which is constitutive resistance, and then aminoglycoside. So amikacin is the IV drug, is the most accurately to M. abscessus complex. And a good solid regime, once you have culture evidence, will always be imipenem, hydrosol, amikacin, and then macrolide. If it's sensitive, without inducible, it's going to be an active drug. If it is inducible, you still add it for its immunomodulatory effect. And then you might have to consider clofazimine in your oral component and amikacin immunization. And so after the genetic results, we'll take our culture, we'll put up a rapid growth centrifugal plate. It takes 7 days to read the first readings, and then 14 days for the macrolides to be finalized. And we keep it for 14 days from a culture-based point of view to assess for inducible macrolide resistance. If it's already resistant on day 7, we finalize there. Otherwise, we wait for day 14 and report it according to the day 14 result. So the core regime is amikacin, tigecycline, imipenem, and then your macrolide for those provisos mentioned. And then sometimes we use linezolid as well. Yeah. And then to remember, imipenem is unstable in culture. So resistance doesn't mean clinical resistance. So we still include the imipenem despite it being resistance, but it is a problem with the methodology.
Thank you.
Still on.
Thank you very much.
Thank you.
For the meeting.
Excellent.
Bye bye, everybody. Thank
You want
you.
one quickly, someone pay for coffee?